Hello everyone. My name is Dr. Stephen Haskins and I'm an anesthesiologist at the Hospital for Special Surgery, which is an orthopedic hospital in New York City, and I'm very excited to be a part of this Sonosite webinar series on point-of-care ultrasound. I'm going to be specifically discussing the emergent role of FoCUS cardiac ultrasound as a powerful tool for the anesthesiologist in the perioperative setting, but when it comes to point-of-care ultrasound, what we're talking about is the use of ultrasound at the bedside. And it has been described as the 21st century version of the stethoscope. And what we mean by that is you're going to be at the bedside and you're going to be simultaneously obtaining images and interpreting those images. And you're using it to diagnose what is often obvious but potentially life-threatening pathology. And so I truly do believe that the use of ultrasound in this manner is not just the next big evolution for us as anesthesiologists, but I believe for the medical profession in general. And so I'm very excited to discuss FoCUS cardiac ultrasound with you all. And I don't have anything to disclose, and I want to start with this image. And so this is an image of the Sonosite iVis. And this is one of many incredible handheld ultrasound devices that are now available on the market. And ultrasound has evolved to the point where not only is it ubiquitous, but it's become so portable that we can literally put it into our pockets and walk bedside to bedside and use it to look inside of our patients and diagnose obvious and potentially life-threatening pathology. And this technology, it's not just innovative, but I believe it's truly disruptive. I believe it's going to change the way in which we think about how we should be evaluating our patients and our medical decision-making processes. Now, I work at an orthopedic hospital, so I can't give a lecture without some form of sports reference, and so I want to talk about what I think is the ultimate competition. And I'm not referring to the World Series between the Cubs and the Indians, but instead I'm talking about the future of the physical exam. And so on the left side of the screen, what we see here is a handheld device. This is the Sonosite iVis, and it's going to go head-to-head with our tried and true stethoscope. And so this was a study that was published in the American Journal of Cardiology back in 2005. So this was over 12 years ago. And what they did was they took two medical students, they gave them 18 hours of training in transthoracic echocardiography, and they gave them a handheld ultrasound device, much like the Sonosite iVis. And they went head-to-head with 5 board-certified cardiologists that could only use their stethoscope and their bedside exam. They were asked to evaluate patients with known cardiac pathology and come up with a diagnosis, and that was ultimately checked against a standard echocardiogram. And what they found was of the almost 240 abnormal findings that were seen on standard echocardiography, the students got the correct diagnosis 75% of the time, while the cardiologists got it 50% of the time. They're more specific in their diagnosis, and they're also more sensitive when it came to non-valvular pathologies. Now, what am I suggesting? I hope you don't think that I'm suggesting that medical students with an ultrasound machine are somehow going to be better at managing patients than board-certified cardiologists, because that's just not true. But what this demonstrates is something that we have seen time and time again, which is that technology has the ability to rapidly bridge the education and experience gap. And so if we take that technology like the Sonosite iVis and we put it in the hands of experienced clinicians and practitioners, and we have the ability to rapidly improve medical management of these patients. Now, this is an editorial that was published in the New England Journal of Medicine back in March of 2014, and it's titled Point-of-Care Ultrasound in Medical Education, Stop Listening and Look. And what we see are some medical students using a handheld ultrasound device as a means to augment their physical exam on this standardized patient. And I really like this quote because I think it embodies the way that I feel about this, which is that a generation of physicians will need to be trained to view this technology as an extension of their senses, just as many generations have viewed the stethoscope. And that development will require the medical education community to embrace and to incorporate the technology throughout the curriculum. And so I work at an academic institution, and we are actively training our residents and our fellows how to use this skill at the bedside. But even if you work in a private practice, you should know that this type of technology and these skills are starting to become very commonplace. And so if you don't stay ahead of the curve when it comes to learning these skills, you'll soon be left behind. I'm going to quickly go through my lecture outline, and I'm going to talk about some of the differences between transthoracic echocardiography and transesophageal echocardiography, which is something we're more familiar with as anesthesiologists. And then I'm going to go through some of the FoCUS cardiac ultrasound views. And I don't expect you by the end of this lecture to feel like you can comfortably go to the bedside and start scanning a patient. That's not my goal. But what I do want to show you is that through pattern recognition, your eyes are going to be able to very quickly start telling the difference between what is normal and what is obvious pathology. I'm going to do a quick literature review touching on the emerging role of point-of-care transthoracic echo and its role in the perioperative setting for us as anesthesiologists, and that's where I'm going to specifically touch on the FATE protocol. And then I'm going to hit on some of the best ways to teach and learn FoCUS cardiac ultrasound. I'm going to go through some clinical cases to demonstrate the ways in which this could be beneficial in your practice. And then finally, this lecture wouldn't be complete without touching on some of the issues with FoCUS cardiac ultrasound. Now, when it comes to ordering a full transthoracic echocardiogram, the American College of Cardiology and the American Society for Echocardiography have fairly strict guidelines. They want you to have either some new or suspicious symptoms, known congenital heart disease, suspected or known pathology, or pre-existing cardiac hardware or valves. And when it comes to ordering a full transesophageal echo, well, the guidelines are even more strict. They want pathology like aortic dissection, endocarditis, or management of an arrhythmia. They want you to have hardware with persistent fever. And obviously, when it comes to anesthesiologists, we're very familiar with transesophageal echo and its role preoperatively and intraoperatively for cardiac surgery. And there's actually been a movement to push the role of transesophageal echo outside of the cardiac ORs and into the non-cardiac ORs for patients who have cardiac pathology but are undergoing non-cardiac surgery. And so the National Board of Echocardiography has actually created a basic transesophageal echo certification, and I was very fortunate at the end of my residency to go through the process of getting this certification. And I just want to very quickly thank Dr. Nicholas Skubis, who is a phenomenal and one of the best and most advanced echocardiography experts on the planet, and he was at Cornell and helped encourage me to get this training. And so I guess the question is, if I went through this whole process of getting training in basic transesophageal echocardiography, why am I here talking to you about transthoracic echocardiography? Well, what I failed to mention is after finishing my residency, I went on to do a fellowship in regional anesthesia. And so all of a sudden, I found myself not doing a whole lot of general anesthetics, and transesophageal echo is generally better performed in a patient under general anesthesia. I also was in a fully orthopedic hospital, a hospital for special surgery, and so transesophageal echo is also more commonly used for cardiac surgery, and there was limited use in orthopedics. And so that was when I shifted my focus to transthoracic echo. And what I quickly found was transthoracic echo was a much more universal tool for me. I could use it on any patient with an exposed chest in the perioperative setting, preoperatively, intraoperatively, and postoperatively. And more importantly, I actually found that transthoracic echo, at least a focused cardiac ultrasound exam, was fairly easy to learn. Why is that the case? Well, I actually think that we as anesthesiologists are the ideal candidates to learn a focused cardiac ultrasound exam. We're already familiar with ultrasound, and looking at ultrasound images, we routinely use it for things like vascular access, for central lines, and for nerve blocks. And we also have the manual dexterity that goes along with optimizing imaging for ultrasound, and that goes hand in hand with optimizing transthoracic echo imaging. And if you take a look at these two pictures here in the upper right hand corner, where you would place a probe for maybe placing a central line in the left IJ or performing a left infraclavicular block, and then you take a look at where you need to place the probe for something like a parasternal view or an apical view, it's just a matter of changing your probe, moving it a few centimeters, and then adjusting your eyes to look at cardiac ultrasound imaging instead of neurovascular imaging. But we really are so incredibly close to doing this on a daily basis, and that's why I think we're the ideal candidates to learn this skill. Now I'm going to go through some of the basic focused cardiac ultrasound views, and again, I don't expect you to come out of this feeling like you can run to the bedside and start evaluating a patient. But what I do want to show you is just by using pattern recognition and showing you what's normal versus obvious pathology, your eyes start to pick up some of these significant and potentially life-saving differences. And so first we'll go through the peristernal views, then we'll go through the subcostal views, the subcostal forward chamber, and also the IVC view. And if you only want to learn one view as an anesthesiologist, I would highly suggest learning the IVC view because it makes a big difference in terms of assessing whether or not a patient is going to be volume responsive when they're hemodynamically unstable. And then finally we'll go through the apical forward chamber view. Now before you start scanning, it's important to have the right ultrasound probe. And so this is an image of the phase array transducer. And the phase array transducer is the optimal probe for ultrasound when it comes to the phase array transducer is the optimal probe for focused cardiac ultrasound because it has a small footprint, which allows it to scan in between rib spaces, and it's a low frequency probe, which allows it to scan deep within the thoracic cavity. Now what I want you to do is, if you're an anesthesiologist, I want you to kind of close your eyes for a second and imagine that you're maybe placing a central line in the left IJ. Or if you're a regional anesthesiologist, maybe that you're performing a left-sided infraclavicular block. Now I want you to imagine which probe you're using. Then I want you to just switch that probe to this phase array transducer. I want you to move it just a couple of centimeters caudad and a couple of centimeters medially, and all of a sudden you're in the perfect position to perform a peristernal long axis view. So for the peristernal long axis view, you're going to place your probe on the left sternal edge between the second and fourth intercostal space, and your orientation marker is going to be aiming towards our right shoulder. And if you do that, then hopefully you'll get an image that looks something like this. And so what we see is our right ventricle is in the near field, and then we see our left ventricle, our aortic valve, our mitral valve, and this is our ascending aorta. And this is a great view to look at basic cardiac function, to assess for obvious valvular disease, look for things like pericardial effusions and volume status. Now, in the upper left-hand corner, we see our normal-looking heart, and then I want you to take a look at this image right here. And so we see in the upper right-hand corner, this black ribbon surrounding the heart there, that's a pericardial effusion. And if you see a pericardial effusion in a patient that's recently showing signs of hemodynamic instability, then that could suggest that there's pericardial tamponade physiology. Now here what we see in the lower left-hand corner is this right ventricle in the near field. It's bulging out, it's ballooning out, it's dilated, and it's showing signs of failure. And so this is someone who is showing right ventricular failure, and if this is a patient who acutely becomes hemodynamically unstable, may suggest that they have signs of a pulmonary embolism. And here in our lower right-hand corner, we see this sluggish-looking left ventricle. It's barely contracted, it's dilated, it's clearly failing, and this is a patient who's going to be at high risk for congestive heart failure in the perioperative setting. Now the next view we're going to look at is the peristernal short axis view, specifically the mid-papillary view. And the good news for this is you're just going to leave your probe in the exact same location that it was for the peristernal long axis view, except now you're just going to rotate the orientation marker so that way it's going towards the left shoulder. And hopefully you'll see an image that looks something like this. And so what we see here is this is our right ventricle in the near field again, and this is our left ventricle. And it's at the level of the papillary muscles. And so this is a great way to look for cardiac function, to see general volume status, to look for effusions, and also this is the image that's very similar to the transgastric short axis view that allows you to assess for myocardial perfusion abnormalities and regional wall motion abnormalities. Now in the upper left-hand corner, we have our normal-looking heart, and it's hard to miss this big black ribbon surrounding our heart in the upper right-hand corner. So that's our pericardial effusion. Again, a patient who's hemodynamically unstable may suggest tamponade physiology. Here, in our lower left-hand corner, we see this dilated right ventricle, and more importantly, you see this D-shaped septum here. If you see that D-shaped septum in a patient who beforehand had a normal-looking heart, that's near pathognomonic for a pulmonary embolism. And then here we see again this sluggish, this dilated, this thinned out left ventricle, a patient at high risk for congestive heart failure. Now the next view we're going to cover is the subcostal 4-chamber view. For this view, you're going to place your transducer directly underneath the xyphosternum, and our orientation marker is now going towards the left axilla. And hopefully you'll see an image that looks something like this. And so we're scanning through our liver in the near field, and then our right ventricle and right atrium again are in the near field. We see our left ventricle and left atrium. We can see our mitral valve and tricuspid valve. This is a great way to look for obvious cardiac dysfunction, valvular disease, and effusions. Now here's our normal looking heart, and here we see that big black ribbon surrounding our heart. So that's our pericardial effusion. Again, could suggest tamponade physiology. Here we see our right ventricle is dilated and failing. How do we know it's dilated? Because it should be about 2/3 the size of our left ventricle. And here it's clearly significantly larger, and our left ventricle looks small and empty. So this is someone who may have signs of pulmonary embolism. And then here again, our left heart, it's dilated, it's failing. This is a sluggish looking left heart. This is someone, again, high risk for CHF. Now the next view I'm going to cover is the subcostal IVC view. And for this, you're going to take your probe and you're just going to rotate it about 90 degrees counterclockwise. So it's pointing cephalad now instead of towards our left axilla. And then hopefully what you'll see is the IVC tracking into the right atrium. Now this is a helpful view because not only does it give you an idea of the potential right atrial pressure, or the CVP, but it can also give you insight into whether or not a patient is going to be volume responsive. And when we think about this view, although these numbers are helpful in terms of its diameter and its collapsibility as a way to get a gauge of what the patient's CVP is, what's more important is the ability to differentiate between this image on our left, where we have a patient whose IVC is totally collapsed, where we see a kissing wall sign, where basically there's no diameter and 100% collapsibility, versus our patient on the right, where we see that this IVC, it's essentially stented open. It looks like a pipe, and there's no collapsibility with respiration. Our patient on the left needs fluid. They need volume. They need crystalloid, colloid, or blood. While the patient on the right, there could be a variety of reasons why that IVC could be dilated, but they are not going to be fluid responsive. Giving that patient a volume challenge is not going to be beneficial for them. Now this was an interesting study that was published in Anesthesiology back in March of 2016, and what they did was they took a look at the IVC diameter and collapsibility before induction of general anesthesia, and they found a general correlation between the diameter and the collapsibility, and they could predict patients who would become hypotensive upon induction of general anesthesia. So this is one of many innovative ways in which people have been looking at focused cardiac ultrasound to help in the perioperative setting. And here's yet another one. This was published in Anesthesiology in April of 2016. And what they did was they looked at the IVC as a means to assess whether a pediatric IV was functioning. And so what they would do was aggressively inject a saline bolus through the IV and then look at the IVC to see if there are bubbles, to see that the IV was in the correct location. So again, more and more impressive and innovative ways in which we're seeing how this can be beneficial for us in the perioperative setting. Now the last view I'm going to go through is the apical 4-chamber view. And for this, you're going to place your transducer at the apex of the heart, so you can feel the PMI, or the pulsus cordis, as a means to guesstimate where to place that probe. But ultimately, your orientation marker is going to be going towards the left back, and hopefully you'll get an image that looks something like this. And so we can see all 4 chambers of the heart. We can also look at our mitral valve, our tricuspid valve, a great way to look at overall cardiac function for obvious valvular disease, and to be able to catch large effusions. Now here we see our normal looking heart in the left-hand corner, and hard to miss that big black ribbon around that heart. That's our pericardial effusion there. Here in the lower left-hand corner, our right ventricle clearly dilated, obviously not less than 2/3 the size of the left ventricle. Instead, it's significantly larger. And here we're seeing this sort of swinging septum. here that suggests that pressure on the right side of the heart is overwhelming that of the left ventricle, which is obviously pathological. And then here again we see a sluggish and dilated left ventricle showing signs of failure in CHF. And I just want to very quickly acknowledge Professor Eric Sloth. He's the one that was kind enough to loan these images of pathology, and he is actually the originator and the inventor of the FATE protocol, who's dedicated his life's work to treating these patients and using focused cardiac ultrasound to improve patient care. So I just wanted to acknowledge him and thank him for these images. Now I'm going to move on, and I want to talk about the emerging role of focused cardiac ultrasound in the perioperative setting for anesthesiologists. Now I wanted to show this issue of ANA from November 2012. And this issue was all about the emerging role of point-of-care ultrasound and specifically transthoracic echo for us as anesthesiologists. And the reason why I find it so helpful, it has this remarkable review article from Colin Royce, and it's titled Physician-Performed Ultrasound: The Time Has Come for Routine Use in Acute Care Medicine. And this article does an incredible job of describing the evolution of focused cardiac ultrasound within anesthesiology. But another reason why I wanted to highlight it is it talks about this notion of the expertise pyramid. Now, the expertise pyramid describes the way in which specialties adapt to new technologies like ultrasound. And you would think when it comes to something like ultrasound that we as anesthesiologists would start at the bottom of this expertise pyramid and we'd work our way up. We'd start with limited echo, using pattern recognition, telling the difference between normal and obvious pathology, and eventually over time we'd become more proficient with ultrasound, getting to the point where we're diagnosing more nuanced pathology, and eventually we become teachers and supervisors in echo labs. Well, when it comes to echocardiography, for some reason in anesthesia, we decided to take a top-down approach. And we didn't want to have anything to do with echocardiography unless we were experts using it in the cardiac ORs for advanced transesophageal echocardiography. Now, there's actually been a movement to suggest that all clinicians should have some form of emergency echo training, so that way they can help recognize and diagnose major causes of cardiac arrest and shock, and therefore use it in acute clinical type settings. Now, if you are interested in learning a focused cardiac ultrasound protocol, the good news is there is a plethora of them out there, a literal alphabet soup, and they all have very clever names like Rush and Free and ACEs and FEAR. But today what I'm going to talk about is the FATE protocol, because that's the one I'm most familiar with and what we've been teaching at the Hospital for Special Surgery. Now, the FATE protocol stands for Focused Assessed Transthoracic Echocardiography, and it's a focused cardiac ultrasound protocol that was initially described in the intensive care setting, but has very quickly been shown to be beneficial in the entire perioperative setting. And what you're doing is you're screening for significant pathology, looking at the heart for signs of volume status, cardiac function, and then you're going to relate it to the clinical context. Now, the FATE protocol views are the ones that we've just gone through, the subcostal 4-chamber IVC, apical 4-chamber, and our parasternal views. But what's important about the FATE protocol and what separates it from a lot of the other focused cardiac ultrasound protocols is it takes pleural scanning into consideration. And as we know, the thoracic cavity is a continuous cavity. And so something like a pneumothorax or a large pleural effusion or a hemothorax can have just as much impact on your cardiac output as something as hypovolemia or pulmonary embolism. And the key here is what we're doing is we're learning how to answer very simple but clinically important yes or no questions. Is the heart empty? Is the heart full? Is the heart working well or is it working poorly? Is there fluid around my heart or lungs? And once you've answered that question, you can then move on, because this is something that can be repeated as frequently as you need, and you can use it to help manage your patient acutely in that setting. And when we talk about the FATE protocol, we don't talk about it as a means of replacing a full transthoracic echo exam or transesophageal echo exam or MRI. Instead, this is a way for you to enhance your clinical exam. And now we're using ultrasound at the bedside, and not only are we able to now listen to our patients, but we can look inside of them and see what's going on. Now, this is the original study that was published in the FATE protocol, and what they did was they took about 200 patients who were admitted to a 20-bed ICU, and they performed a FATE exam on these patients. And for the patients that they couldn't get any views, they went on to perform a transesophageal echo. And what they found was, of these 210 patients, they found usable images in 97% of the patients. So almost every single patient, they were able to get a view. And in 25% of those cases, the information was decisive, meaning that it led to the diagnosis and eventual management of that patient. And the rest of the time, it was either supplemental or supportive. So there was never a scenario where it wasn't beneficial to put the probe on the patient's chest and to look inside. Now, this is the 21st century, so if you are interested in learning more about the FATE protocol, there is an app for it, and it's available on the Apple and Android markets. But more importantly, there's a course for that, and this is something that we've been teaching at the Hospital for Special Surgery to our residents and fellows. And since we first held our course back in March of 2013, we've then gone on to lead 9 more for a total of 10 courses, 4 of which have been CME accredited, and we've trained over 200 clinicians in basic FATE and provided certifications. And I was very fortunate to be awarded an innovative educational grant to fund 2 courses for our residents and fellows, and this provided funding not only for the training but also a research project to look at whether or not they were learning anything from this, if this was providing any benefit for them at all. And so what we did was we enrolled 22 residents and fellows after getting IRB approval, and we looked at several different outcomes. We looked at they had an online e-learning course, so there was a pre-test and a post-test, and we looked at their scores, and then we had them acquire images, and we graded those images, and we graded it prior to a hands-on training course, immediately after a 6-hour hands-on training course, and then we had them come back 6 months later and look at the retention of this skill. And what we found was the median change for the online e-learning was about 40%, so they're actually learning something with this online course. And their changes in their image acquisition score from pre-course to post-course was about 10%, which was statistically significant. And so they actually did learn a lot over the course of those 6 hours. And we had as many of them as possible come back 6 months later, and we took a look at their ability to scan and their ability to retain this skill 6 months later. And what we found was there was an even greater improvement from their pre-course to the 6 month later retention imaging, up to about 18%. And just anecdotally, I think it was interesting to note that you would say maybe obviously they're out, they're practicing, they've been using it for 6 months, that's why they did better 6 months later, but the reality is a lot of them said they didn't have opportunities to use it. So I was actually very impressed to see that 6 months later they still had the ability to get these images. So just an interesting finding there. Well, what I alluded to earlier is that learning a FoCUS cardiac ultrasound exam is something that's easy to learn. Well, how easy is it to learn? You have a lot of tools out there. We talked about hands-on training courses as one way, but this is an image of some of the simulators that are available out in the market that you can utilize to help learn the skill, and I certainly did use it when I was first beginning to learn it. But I often equate learning a FoCUS cardiac ultrasound to learning how to perform ultrasound-guided regional blocks. It's going to be user-dependent, it requires education and training, and there's often a steep learning curve. So I guess the question is, when should we start learning the skill, and how much time do you need to be proficient at it? Well, the University of South Carolina School of Medicine has actually started integrating ultrasound training into their medical student curriculum. And we saw these Harvard medical students before who were using a handheld ultrasound device to augment their physical exam. And this is a recent cover of Anesthesiology, September 2015, and it was all about teaching and learning point-of-care ultrasound. And the article that was highlighted by this issue was by Davinder Ramsingh and his colleagues at UC Irvine. And they looked at the impact of a perioperative point-of-care ultrasound training program on their anesthesiology residents. And what they designed was this comprehensive head-to-toe point-of-care ultrasound exam. That's FoResight, and it stands for Focused Perioperative Risk Evaluation Sonography involving gastroabdominal, hemodynamic, and transthoracic ultrasound. So this is truly a head-to-toe exam. And they took their CA 1 to 3 residents, they gave them a training in this again, head-to-toe point-of-care ultrasound exam, and this was a 2-year FoCUS curriculum. They gave them didactics, followed by simulation, followed by hands-on training, and it was reinforced in the clinical setting. And in my opinion, this really is the gold standard. This is how we should be teaching the next generation of anesthesiologists how to learn point-of-care ultrasound. But with that said, there have been studies that have shown that limited training can address simple yet clinically important questions while using FoCUS cardiac ultrasound. And so this is just a study that demonstrates something that we as anesthesiologists know very well, which is patients with moderate to severe aortic stenosis are at higher risk of having cardiac complications and death. And so this study that was published in Anesthesia back in 2011 took 5 anesthesia trainees with no prior transthoracic echo skills and training, and they gave them a 1-hour lecture on transthoracic echo and how to evaluate for aortic stenosis, and then 1 hour of hands-on training. So this is just 2 hours of training altogether. They were asked to go evaluate 20 cardiac patients. They were blinded to their diagnosis and just told which views to obtain, and then ultimately their diagnosis was compared to that of an attending cardiac anesthesiologist. And what they found was between the trainees with just 2 hours of training ahead of time and the attending anesthesiologist, there was 100% agreement in diagnosis of moderate or severe aortic stenosis, and over 90% agreement in peak velocity, and it only took them about 5 to 10 minutes to perform this exam. So just limited training can still give you the skill set to be able to diagnose something that can have a major impact in the perioperative setting like aortic stenosis. Now, this is a recent special article that came out in ANA, and it was a call to action that there should be a structured perioperative ultrasound training program for all anesthesiology residencies. And I was very fortunate to be a part of this special article, but they gave very specific recommendations, which is that during anesthesiology residency, perioperative ultrasound training should be continuous and structured, and because of the importance of ultrasound to the evolution of anesthesiology as a specialty, it would be prudent to develop and implement fundamentals of perioperative ultrasound education and training to be universally adapted in accredited anesthesiology training programs. And so, as I said, this is something that is inevitable, and if you don't stay ahead of the curve, you're going to be left behind very quickly. Now, I want to go on and I want to talk about some of the ways in which a FoCUS cardiac ultrasound can be relevant in your clinical practice. And so I want to give some clinical cases. And so the first case I want to talk about is called AS. It's a preoperative assessment of a patient, and I like to call it the good, the bad, and the ugly. And so this is a patient that you would very commonly see maybe if you're on call on the weekend, on a Sunday. The orthopedic surgeon gives you a call and they say, we have this patient, she's 87-year-old female, she has no known past medical history. What does that mean? It just means she hasn't seen a doctor in about 20 years. And she fell, she has a femoral neck fracture, and she's being scheduled for a TFN. So this is ortho, so they're saying she has a fracture, we got to fix it. She has a fracture, we got to fix it. And so they want to rush to get this patient off to the OR. So you say, hold on a second, let's take a look. So take a look at her vital signs, 160 over 80, heart rate's 85, satting 95 on room air, not too bad. But you take a listen to her and you hear that something that sounds like maybe a systolic murmur radiating to the carotids. Your EKG shows some increased voltage in the lateral leads. Her chest x-ray is clear. And so you're concerned that this patient may be someone who has aortic stenosis. And so you decide to do a FoCUS cardiac exam just to assess whether or not this patient may have this worrisome cardiac pathology. And so here is AS, the good. And so you put the probe on the patient's chest, and here's what you see. So here's our aortic valve, and it's opening and closing beautifully. This is a patient who clearly doesn't have aortic stenosis, and her left ventricle looks fine. So this is someone who you feel comfortable going forward with the case and having normal intraoperative and postoperative management. Now here's AS, the bad. Now you put the probe on the patient's chest, and what do you see? So she's got this calcified, barely opening, hyperechoic aortic valve. So that's someone who you're worried may have moderate to severe aortic stenosis. but you take a look at her left ventricle and it seems to be functioning fairly well. And so this is someone who maybe you're going to change your intraoperative management. Instead of giving a big whopping spinal or big whopping propofol dose for induction, perhaps you'll do a more gradual titration with an epidural or use something like etomidate. And more importantly, intraoperatively and postoperatively, you're going to change your management from the perspective of the monitors that you're going to place and also where they're going to go afterwards. You're not going to send them to the normal PACU, but instead maybe a step-down unit or an ICU. Now I'm going to change our scenario ever so slightly, and we still have the same patient with the same vital signs. But now you take a look at the physical exam and she's got 2+ bipedal pitting edema. You listen to her heart, and it's been a while since you've heard an S3. It's been a while since your cardiology rotation as a medical student, but something doesn't quite sound right there. And EKG, again, increased voltage in the lead. Chest x-ray looks relatively clear. So again, it's time for you to put the probe on the patient's chest and evaluate for cardiac function and obvious valvular disease. And this is AS, the ugly. And so aortic valve actually looks okay, but here we see a sluggish looking left ventricle. This is our dilated, bulging out right ventricle. Here we see this near pathognomonic symptom for right heart failure, which is that septal deflattening. And so this is a patient where you say, hold on a second, this shows signs of biventricular, we're seeing dilation, failure. This is someone who needs to be evaluated by a cardiologist, and I can't just rush to have them off in the operating room. And you ultimately postpone the case, and this patient is diagnosed with severe pulmonary hypertension, biventricular failure, and is ultimately put on palliative care because they're not going to be able to tolerate any type of anesthetic. And so this is the way in which this could be beneficial for you in the preoperative setting when you're trying to triage patients that you know need to go to the OR urgently, but you want to make the right medical decisions intraoperatively and postoperatively for that patient. Now I want to move on and talk about the role in the postoperative setting. And so this is still our same patient, AS, but I like to call this one, what type of shock? And so we still have our 87-year-old patient, maybe this is AS the good, and she presents immediately postoperatively after the TFN. And you're called to the bedside to assess her because she's now become hemodynamically unstable. And so you take a look at her and her vital signs. She's hypotensive, she's tachycardic, she's a little bit hypoxic on 4 liters nasal cannula. The EKG shows sinus tachycardia, so no massive MI there. And the case was a big case. It was a long case, a significant amount of blood loss, but it looks like she was resuscitated appropriately in terms of her crystalloid and colloid. Urine output is adequate for that duration. And so you say, I need to put a probe on the chest and do a FoCUS cardiac ultrasound to assess for cardiac function and volume status. And this is the reason why it's so important to perform a FoCUS cardiac ultrasound exam. Because when you approach a patient who's in shock, on the outside they all look exactly the same. They're hypotensive, they're tachycardic, they're diaphoretic, they're hypoxic. They just look terrible. On the outside, they all look the same. But on the inside, they all look incredibly different. So in the upper left-hand corner, we have a left ventricle that's failing, that's barely contracting. This is someone that may have a septic cardiomyopathy or potentially could have had a massive MI. Here we see a patient that's hypovolemic, that needs volume, that needs crystalloid, colloid, blood. Here we have a patient who's got a large effusion that's presenting in the form of tamponade physiology. Here we see a large pleural effusion that's affecting the cardiac output and volume and filling status. This is a pulmonary embolism, and this is a heart with massive heart with signs of diastolic dysfunction. And the management for these patients is so dramatically different. The patient in the upper left-hand corner needs inotropes to help with cardiac output and function, while the patient in the middle needs crystalloid, colloid, or blood. We need to be able to drain these effusions, these pericardial and pleural effusions, and this patient, you need to rush them off to the cath lab for an embolectomy. And this really is the most difficult heart to manage. And the reason for that is if this patient arrests, there's nothing you can do about it. It's near impossible to do chest compressions in a heart that looks like that. but you need to know that you're dealing with a heart that has those signs of diastolic dysfunction before you start making your management decisions. And so this is why, again, it's so incredibly important that we assess our patients, not only looking at them from the outside, but using ultrasound to look inside and see what's going on. So finally, I want to touch on some of the issues of focused cardiac ultrasound. And depending on who you're talking to, this could potentially be a whole lecture. I'm a little bit biased, so it's just going to be a few slides here. But I think the biggest thing that comes up when we start talking about focused cardiac ultrasound is that there's no real certification or regulation for it currently in the US. Now, the National Board of Echocardiography, they do have a certification for transthoracic echocardiography, but that's at the very top of that expertise pyramid. It's essentially only meant for cardiologists, and it's a very difficult test to take and pass. Now, the good news is there has been some movement towards acknowledging that this is an important skill for us clinically. And so the American Society of Echocardiography put out an expert consensus statement with recommendations on what type of clinical scenarios you should be using focused cardiac ultrasound. And there has recently been an international evidence-based recommendations for focused cardiac ultrasound. And these are lengthy articles that talk about all the different potential clinical scenarios in which this could be beneficial and when it should be used and when it should be deferred to a full transthoracic echo exam. The Society of Critical Care Medicine recently came out with recommendations for focused cardiac ultrasound as well, but unfortunately they only are willing to certify people who are fellowship trained in critical care medicine. But at least they give us a number, and they say, we need at least a minimum of 50 interpreted and perform 30 exams. So at least we're starting to move in the direction of knowing what are the requirements to become competent in focused cardiac ultrasound. Now, probably the most common question that I'm asked when I'm giving lectures or I'm teaching courses is, what are the medical legal implications of missing a diagnosis or perhaps getting the wrong diagnosis when it comes to focused cardiac ultrasound? And it's a very valid question, but my answer is always, you need to know, one, the limitations of this exam, and that's the case with any point of care ultrasound exam, and two, what is your comfort level? Is this something that you just took a course last weekend, or have you been practicing this for 6 months or a year? Remember, if you ever have a question, you should call an expert. If you're an anesthesiologist, that may mean calling on one of your cardiothoracic colleagues or performing a full echo, because this is meant to be a guide for therapy. We're not trying to replace cardiology, but instead it's a means for you to look inside your patient and get information in real time. And always put it in clinical context. We do not treat ultrasound images, we treat patients. And so the second that you start making decisions based on an image instead of putting it in the complete clinical context, that's where you're going to get in trouble. And then finally, reassess. That's the benefit of having this tool, is that you can go to the bedside repeatedly and look inside and see what's going on. And often these types of pathologies evolve quickly. And so the imaging that you had 10 minutes ago or half an hour ago may not be the same as what's going on right now. So hopefully, in conclusion, I've been able to demonstrate that focused cardiac ultrasound is a helpful additional tool for you, particularly in the perioperative setting. It's fast, it's mobile and becoming increasingly mobile with these handheld devices, and it's non-invasive. It gives us visual real-time information about what's going on inside of our patients and is a powerful tool to answer simple yet potentially life-saving clinical questions. It's easy to learn, and I think because of that, it's going to become even more commonplace. And I guess the real question is, at some point, will this be considered standard of care? Will the expectation be that every time that you perform a physical exam, you should be ultrasounding the heart? Well, I think as more and more of these handheld devices like the Sonosite iVis make their way onto the market, I believe that that will be the case. And so thank you very much for your attention. I'd like to thank Sonosite again for this opportunity to talk with you all about focused cardiac ultrasound. And I hope that you go out there and start to learn this skill.